Did you know that women in the United States are more likely to die from childbirth than women living in other developed countries? While this problem is multifactorial in nature, a few key issues have been identified by the CDC that have the best odds of being addressed through a healthcare approach. These best odd factors can be found in the U.S. Department of Health and Human Service, Office of Disease Prevention and Health Promotion's decade-long, measurable goal-based initiative, Healthy People 2030. Within this initiative, measurable objectives are created to address specified goals. Healthy People 2030 is the initiative's fifth iteration. Within this fifth iteration of Healthy People, it is recognized that not only does a woman's health impact the woman, it also has a major impact on her infant's health and well-being. In essence, when you treat an expecting mother, you have two clients to consider with intertwined co-occupations, intertwined physiological and psychological stabilization, as well as intertwined overall health. It is little wonder, then, that Office of Disease Prevention and Health Promotion would focus on nulliparous, multiparous, and primiparous women, or expectant moms, if you will. Healthy People 2030 focuses quite heavily on maternal health. In fact, one national goal is to prevent pregnancy complications and maternal deaths and improve women's health before, during, and after pregnancy. In order to support this goal, the CDC has established several objectives related to it, including reduce maternal deaths, reduce severe maternal complications identified during delivery hospitalizations, and reduce cesarean births among low-risk women with no prior births. Up until this point, you might have been following along expectantly, waiting for me to bring OT into this. Okay, you might think. This sounds like a serious problem, but how does it include me? Occupational therapy's role in treating women's health is peculiar. Despite the fact that as of 2019, 91% of occupational therapists are women, occupational therapists have been historically absent from settings within women's health. In fact, it wasn't until 2018 that the American Occupational Therapy Association announced a women's health special interest section of the AOTA community of practice. Conversely, the American Physical Therapy Association formed a women's health specialty in 1977, though they had far fewer female practitioners proportionally represented in the profession at the time compared to OT. Occupational therapists are not waiting around for state or national leadership to establish women health specialties, however. Through grassroots efforts, thought leaders in occupational therapy and women's health have created practices and communities of like-minded individuals. These groups have been organized to develop occupational therapy within a women's health framework. In fact, it were thought leaders Melissa LaPointe and Lindsay Vestal who created Women's Health for OT in 2014, a Facebook group for professional occupational therapists. By the beginning of 2021, the group had over 4,000 members. In the summer of 2020, I surveyed 232 mothers and 43 occupational therapists regarding childbirth. I used a snowball sampling method among members of respective special interest groups on social media, as well as personal acquaintances. Participants anonymously responded to either the 21-question assessment for mothers or the 10-question assessment for occupational therapists. The assessments were completed via Google Forms, and the assessments were open for 7 days only. I will report on the results of the mother-based assessment first, and then move on to occupational therapists. Of the 232 mothers, 70% had delivered their most recent child within the last 5 years, demonstrating recency in their experiences. In addressing the most difficult challenges during the maternal period, the top 10 reported difficulties, in order from most cited to least cited, included 1. Body changes, 2. Intimacy changes with partner, 3. Breastfeeding, 4. Loneliness, 5. Changes to identity, 6. Having to return to work too soon, 7. Relationship changes, 8. Loss of participation in meaningful activities, 9. feelings that your body no longer belong to you, and 10, difficulty completing everyday activities. Of the 43 occupational therapists who participated, only 14% of respondents reported learning about prenatal, perinatal, or postnatal care in the respective OT programs. Yet 100% of respondents found it at least somewhat important for occupational therapists to be involved in women's health generally and the maternity ward specifically. In addressing the most important potential roles for occupational therapists in the maternity ward, the top 10 reported roles in order from most cited to least cited, including 1. Safe infant handling, 2. Ergonomics training, 3. Prevention of repetitive use injuries, 4. Education on infant development, 5. Breastfeeding support, 6. Training on the importance of attachment styles, 7. Rehabilitation following a C-section, 8. Transition planning, 9. Pain relief, and 10. Information on resuming sexual activity. Noticeably absent from the top 10 selections was prevention of adverse mental health conditions. However, qualitative responses from OTs indicated a mental health focus in other responses, such as attachment style training and transition planning. When comparing practitioner potential role responses to challenges reported by mothers, there were some areas of overlap. However, intriguing disparities were more common. For example, practitioners did not cite mental health in their top 10 most important roles, yet mothers reported 4 mental health care responses. Occupational therapists highly ranked 3 infant-centered roles, but mothers did not mention any infant-centered roles. Further, therapists cited 4 biomechanical roles, whereas mothers cited only 1. Areas of overlap included breastfeeding and intimacy with partner. These results indicate a mental health gap in service reported by postpartum mothers. Conversely, occupational therapists predicted a gap in service and value, most related to biomechanical interventions. This disparity between therapist responses and mothers may be due in part to therapists' lack of specific education regarding postpartum mental health during their OT school programs. Such a gap in focus likely leads to a lack of awareness. Based on these results, I have been developing a 14-week program to address maternal health broadly and postpartum post-traumatic stress prevention specifically. My program will be implemented at Centennial Hills Hospital during the spring of 2021. In the 5 years that Mental Health America has rated and ranked the state of mental health in America, Nevada has never risen above 47th of 51 states. In fact, the 2021 overall rating puts Nevada in the 51st position out of 51. In response to Nevada's dire mental health situation, Governor Sisolak has declared Nevada in a state of mental health crisis as of 2018. Evidence has indicated that after community social distancing, mask wearing, and heightened stress, Nevada is expected to have a disproportionate and negative mental health impact following COVID-19 closures. As of November of 2020, Nevada had a higher rate of child and adolescent suicide than any other state in the nation. And by February of 2021, Las Vegas had the worst unemployment rate among cities of 1 million people or more. And we know that nationally, job losses have impacted women 4-to-1 when compared to men. As occupational therapists, we understand the importance of occupation, both as formal work and in regard to the 8 other occupations. Such negative outcomes are likely to continue to impact vulnerable populations, such as children, adolescents, their mothers, as well as pregnant and newly delivered moms. Unfortunately, Nevada is also a state that lags behind others in regard to maternal health care, and up until the 2019 Nevada State Legislative Session, was one of only 7 states that lacked a maternal mortality review committee. Like postpartum depression, postpartum post-traumatic stress disorder can impact mothers' mortality, and certainly their ability to effectively support attachment styles and their own children's mental health outcomes. The threat to pregnant women is so dire that researchers have called on facilities, cities, states, and countries to develop a detailed mental health crisis program for expecting and postpartum women. It is for this reason that mental health preventative care for women in Nevada is vital. Yet, Nevada remains understaffed in the area of mental health care providers. Occupational therapists are trained in mental health and have the ability to close the gap in relation to both maternal care and mental health. It's clear that this national and state trend in women's health has the potential to impact maternal outcomes well into the future. And with OT's holistic focus, OT practitioners are needed at the table. Certainly, occupational therapists have many tools to address mental health and biomechanical issues. But there is so much more that we can do. The best approach when treating any client is a holistic one that meets the specific needs of each individual. When working with mothers, this is no different. As occupational therapy has an inherent holistic lens, we are well situated to address many currently unaddressed areas of care. Right about now, you're asking yourself, if there are few if any occupational therapists in women's health, why should I even invest in learning more? But I would reason that occupational therapists do treat mothers in other settings, just not exclusively. Since this is not a well-understood population by occupational therapists due to a lack in education and training, this is something we will have to pick up in continuing education. But what settings do occupational therapy practitioners currently treat moms during pregnancy within the first year after? Some areas include the NICU, early intervention, pediatric home health or mobile outpatient, hand therapy, and outpatient therapy. There are many pregnancy-specific conditions that require OT, such as pregnancy-related carpal tunnel syndrome, which occurs in part due to an increase in blood volume during pregnancy, lower back pain from increased lordosis, a changing center of gravity, increased weight gain, primarily a mass ventrally, and poor body mechanics, and finally, repetitive use injuries from frequently holding the infant. In one of my level 2 clinical rotations, I treated a baby under a year old. His treatments occurred in their home during COVID closures. He was the youngest child of 3 boys. The oldest 2 had been diagnosed with autism. They were enrolled in virtual learning. To make matters more difficult, their father was deployed in the military. The child's mother had ADHD herself and was managing a collective 18 hours of various therapies a week for her sons, in addition to managing school days. During the course of treatment, it became clear that this child's mother was completely overwhelmed. She sobbed during therapy sessions and pleaded for direction in managing her own valued occupations and all the various IADLs she was sole provider of during an era of COVID closures. She felt unsupported and isolated as she was separated from her partner, her extended family, and due to COVID, her military family. As I relate this case study, your OT brain is likely already whirling with possible solutions or approaches to helping this mom, because we all know that baby will only do as well as baby's guardians are doing. We worked with this mom on occupational balance, performance patterns, IADL tips and tricks, environmental factors like support and relationships, encouraged mom to speak to her physician and seek out psychotherapy, and in order to minimize the amount of therapy sessions the mother had to coordinate, we collaborated with the family's PT and SLP to co-treat. While this mother was at the end of her postpartum period, there are many other scenarios within the prenatal, perinatal, or postnatal periods. To briefly touch on examples of areas occupational therapists can treat in relation to various stages of the maternal period, let's explore the Occupational Therapy Practice Framework, Domain and Process, 4th edition. This new edition of the OTPF created a 9th occupation, health management, and broadened occupation to more than just the individual level, adding the group level and population level. For our purposes, let's focus on the individual level, though occupational therapists could certainly work at other levels within women's health. Throughout pregnancy and beyond, occupations are made more difficult and their balance is negatively impacted. The mother's client factors are impacted by drastically changing body and then managing a tiny, needy baby while also trying to recover from pregnancy, labor, and delivery. Examples include sleep participation, rest, intimate partner relationships, friendships, leisure participation, play, job performance and maintenance, education, nutritional management, symptom and condition management, home establishment and management, meal preparation and cleanup, child rearing, financial mobility, personal hygiene and grooming, toileting and toilet hygiene, dressing, eating and swallowing, as well as functional mobility. This list is by no means comprehensive. In order to meet the changing occupations and client factors, the mother needs to develop new skills, learn how to manipulate environmental factors to better support mother, increase personal development in personal factors, improve performance patterns, and address performance skills as needed. Working with this population includes assessments and interventions normally found in early intervention, acute or subacute care, and a mental health setting. Each mother has unique needs that will necessitate an in-depth occupational profile to direct the focus of goals and treatments. As obstetrics occupational therapy is an emerging practice area, OT practitioners' roles are likewise emerging. A 2018 article by Fernandez outlines a health promotion approach for occupational therapists treating women in the maternal period. She calls for preserving occupational balance during this stage while utilizing evidence from the orthopedic setting, rehabilitation, and hand therapy. One level 3 study found that 67.4% of women complained of hand or wrist pain during pregnancy. This is the second most common musculoskeletal complaint during the maternal period, following lower back pain. At the source of this pain may be prolactin and increased fluid retention, which loosens the joints during pregnancy and puts increased strain on said joints. Left unaddressed, this pain may lead to peripheral neuropathies and maladaptive posturing to avoid feelings of neuropathy. Poor posture during repetitive childcare occupations increases the risk of tendinosis and leads to pain in the elbow, epicondylitis, shoulder, rotator cuff tendinopathy, and the neck. Because women expect maternal pain, they do not report instances of aches and pains unless a healthcare provider expressly asks about musculoskeletal pain. Due to the episodic nature of these musculoskeletal injuries, it is advised that conservative treatment, rather than surgical interventions, should first be employed in the form of therapy. The Boston Carpal Tunnel Syndrome Questionnaire is a valid and reliable assessment that is suggested for practitioners to use in monitoring outcomes. Another common injury of the upper extremities in the postpartum period is de Quervain's tenosynovitis, which involves the inflammation of the abductor pollicis longus and the extensor pollicis brevis tendons. It frequently occurs secondary to a deviated thumb and wrist with weight bearing, movement, and repetitious movements to lift and hold the infant during feedings and care. Surgery is not recommended for this population due to the IADL demands that come with an infant. Further, a multimodal approach including injection, orthoses, and therapy are recommended for best outcomes. Fernandez cited health promotion as extremely important when treating women from a lower socioeconomic background, as these individuals tend to get delayed obstetric care, frequently lack partner support, and are at a higher risk for musculoskeletal injury during the antepartum period. It is advised that occupational therapy practitioners educate OBGYNs, midwives, and other primary care providers who treat pregnant women. Therapists should relay the commonality of maternal orthopedic conditions, and the occupational therapists have the skill set to treat the conditions after they develop, as well as to provide preventative treatments. Further, instilling preventative occupations is important in keeping injuries at bay during the maternal period. Fernandez suggests that OT practitioners utilize technology to create and promote digital content that educates the public on the role occupational therapists have among this population. A mixture of social media and applications are specifically suggested. Occupational therapists can use social media to educate and motivate mothers to attend to their posture, strengthening, positioning, and provide tips to remain healthy. Another use of social media, in conjunction with applications that track symptoms, is also suggested. Specifically, it is recommended that OT practitioners highlight applications that track common carpal tunnel syndrome symptoms and educate the public to bring this data to the physician's attention should there be a potential problem. The author also highlights the importance of occupational therapists providing emotional support and validation for new moms, as well as training them on how to safely and effectively care for their child. In this approach, Fernandez promotes the biopsychosocial frame of reference when treating in the perinatal population. The author acknowledged that most OT practitioners currently treat women after an injury or dysfunction has arisen, and she resultantly recommends practitioners educate moms on changing routines and modifying childcare techniques to prevent further repetitive injury, as well as use custom orthoses, patient education, strengthening, postural control, activity adaptations, and ergonomics training, utilizing breastfeeding pillows, bath stands, correct use of baby carriers, and providing a safe home exercise routine in order to address post-injury treatment. On a macro level, Fernandez recommends that OT practitioners educate primary care providers, hospital management, and government legislators to promote the role of occupational therapists in maternal care. Further, she suggests that practitioners host orthopedic workshops on pregnancy and network with obstetric providers. Said workshops are suggested to focus on orthopedic concerns, and after a relationship has been built with physicians, other occupational features should be expanded upon and addressed. As this emerging practice area deepens, advanced research will follow to prepare occupational therapists for maternal care. In a brief capstone literature review, I found 7 capstone projects in the area of maternal health. Most were published in 2020, but none were earlier than 2017. The titles include Postpartum Pelvic Floor Intervention and OT by Shelby O'Connor, The Secret Ingredient for Improving Infant-Child Mental Health, Teaching Parents to Play, which focus on attachment, by Geraldine Healy-Marini, Occupational Therapy's Role in Maternal Mental Health Within Transition from NICU to Home, by Victoria Briltz, Supporting the Role in Transition to Motherhood Through the Occupation of Feeding, by Beth Ann N. Vidmar, Creation of Health and Wellness and Self-Care Tool for Mothers of Infants Requiring a Neonatal Intensive Care Unit Stay, by Genevieve McCarthy, Occupational Gearing for Child Rearing, Occupational Therapy's Role in Helping New Mothers Succeed After Giving Birth, by Alana Grabarkowitz and Lydia Swanson, Mama Stay, Exploring the Role of Occupational Therapy in Maternal Health with an Occupation-Based Yoga Program, by Sarah O'Connor. The subjects of other studies I ran across included Supporting Mothers Through Postpartum Depression, Attachment Theory Between Mom and Baby, Shaken Baby Syndrome, Aquatic Exercise During Bed Rest, Occupation-Based Retreat After Pregnancy or Infant Loss, Relaxation Interventions for Mothers on Bed Rest, Stress Reduction Techniques for Mothers, as well as treating mothers with specific disabilities. However, the most striking information I found came from USA Today. They have published an investigative piece via a multi-part series on maternal care under the collective title Deadly Deliveries. This series focused on the maternal death rate in the United States and what failures have led to this outcome. They pinpointed 2 specific causes. 1, maternal stroke following a lack of pharmacological therapy upon identifying high blood pressure, and 2, women hemorrhaging to death. There were 2 simple preventative care treatments that struck me. The first involved educating mothers during pregnancy as well as following labor and delivery on the importance of maintaining healthy blood pressure. This is particularly important for women who have hypertension during pregnancy. The other preventative treatment that struck me is simply weighing mothers' used feminine hygiene pads following labor in order to pinpoint when a woman has lost too much blood. This is a simple protocol that occupational therapists could be involved in if the hospital systems continue to fail to do it via existing staff. OT practitioners could train the mother or her birth partner on the importance of weighing her pads to identify potential hemorrhaging, provide the guidelines for dangerous weights of pads, when to call their obstetrics provider or emergency services, and train mothers in the hospital on how to do this while in the hospital and until they stop postpartum bleeding. We could then send them home with a scale or directions to purchase one, a blank chart for documenting, and a reference sheet of unacceptable pad weights. We could then provide them with alternate ways of completing everyday activities that will help them prevent hemorrhaging once they return home. In our profession, we already train clients on perinatal care, feminine hygiene, reproductive health, and routines. We could easily train postpartum women on this as well, and it could save lives. Focusing on health and wellness treatments, there's one intervention that has particular appeal. This specific treatment is yoga. Move and Thin completed a 2019 narrative review of yoga during pregnancy. He found that the following were positively impacted: mental health, physical fitness, decreased chance for preterm birth, improved vital signs, decreased pregnancy-related discomfort, better sleep, improved interpersonal relationships, healthy infant weight, enhanced mother's immune functions, decreased labor pain, optimal fetal positioning during labor, prevention of pharmacological and invasive methods of pain management during labor, decreased length of labor, reduced assisted vaginal delivery, increased comfort following labor, improved overall childbirth experience, decreased labor augmentation, improved infant APGAR score, higher childbirth self-efficacy, improved coping skills, reduced depression and anxiety, improved intrauterine fetal growth and uterofetal placental circulation, reduced pregnancy complications among women who have abnormal umbilical and uterine arteries, reduced hypertensive pregnancy-related complications, glycemic control among women with gestational diabetes mellitus, increased maternal fetal attachments, and decreased stress. During the postpartum period, it produces significant reductions in body weight, body fat percentage, fat mass, and basic metabolic rate. Following a stillbirth, it helps women cope with their grief and decreases depressive symptoms. Pregnant women should not participate in hot yoga, as it carries an increased risk of injury, problems maintaining a healthy blood pressure, and an increase of neural tube defects and malformations. Yoga has rarely been associated with the following adverse outcomes: retinal hemorrhage, emotional distress if combined with meditation at home alone, and an increased incidence of postpartum intrapartum hemorrhage. However, yoga is considered safe during pregnancy. Therefore, I would suggest yoga as a health promotion activity for women in the maternal period who have been cleared to exercise by their obstetrics provider. Each positive impact supports the goals in relation to maternal health. This leaves yoga in a prime position to be considered when treating women who have given birth recently but who are cleared to exercise, as well as women who are expecting. Over the course of this presentation, we have explored the role of occupational therapists in the maternal period, emphasizing a health and wellness approach. This approach is vital, as the deadliest place in the industrialized world to give birth is the United States. This is sobering and completely unnecessary. Occupational therapists have the skill set to provide simple and cost-effective preventative care to keep mothers from, in the worst case, dying, but also from suffering. Healthy People 2030's goal to prevent pregnancy complications and maternal deaths and improve women's health before, during, and after pregnancy can be accomplished via a current missing link. us, occupational therapists. Thank you.